Well, thank you all for showing up here tonight. I'm sorry the weather didn't cooperate, but it's nice to see you all here. Like Rob said, my name is Matt Greaves. I work for A.T. Still University. Just kind of wanted to go a little bit about myself. I went to my undergraduate degree through Westminster College in Fulton, Missouri. I lived in this house here for 4 years. I took all my classes in this building right there. Really tiny little school in the middle of the state, but I had a great time. Afterwards, went to dental school in UMKC, graduated with a couple of the guys here. And this is what it looks like on the outside for those of you who haven't been there. That's the only windows in the whole place that we have, unfortunately. The clinic's essentially in the basement, which is kind of sad. But I took this photo when I was there. This was in the oral surgery department. And I don't know if you guys remember, they have these old wooden slats that held the magazines there. And this magazine was positioned just perfectly in the oral surgery department, and I got such a kick out of it. I can't imagine being a patient there and reading this thing and thinking, oh my God, it's time to die. But that was kind of like what dental school is like for us. I went to a GPR. I did 2 years of a general practice residency at the University of Minnesota Medical Center, which is located in downtown Minneapolis. So here's a photo of the Minneapolis side of the Twin Cities. What you see lit up there is the bridge. It's a Stone Arch Bridge. Actually, a weird kind of fact is that this is the farthest north that you can take by boat up the Mississippi River. There's a lock that's right there that has been operated by the Federal Park Service, but it's no longer in function anymore. So that's where the trip ends. When you look at this photo here, this is the east bank of the University of Minnesota. So this really tall white building right there, that's the dental school. So it's a huge building. I did a lot of work out of there. This more kind of brown brick-colored building right there, that was one of the hospitals that we would sometimes see some of our hospital cases for special needs patients in the operating room. But you can see it's right in the heart of downtown. It was a great place, learned a lot of great cases, a lot of good experiences, really enjoyed my time up there. Here's a photo of, again, downtown Minneapolis. Land of 1,000 legs or 10,000 legs. It's awesome in the summer. It's perfect right now. In the wintertime, not so much, with the exception of what is one thing called the Loppet Festival. So this was kind of cool. And when you look at these photos, you see those lakes, so they'll freeze over, obviously. And then they turn it into this big cross-country skiing kind of art festival with music and kind of lit up sculptures and whatnot. It was really beautiful. So they made the best of the winters up there. This is a couple photos of my wife and I on our wedding day, obviously, and then one of our trips that we took recently to Alberta. We got a small dog up top there. He was one of the officiants of the wedding. So we've been married for a few years now. I've got some baby photos. We have a new 4-month-old at home, so you'll see some pictures of him here at the end. That'll be something to keep everybody awake and on track. My father's a dentist. My brother's a dentist. My wife is a dentist, so we're all weird like that. This is actually a photo from when my brother graduated. It's kind of cool. In Kansas City, we were able to place the hood over him for his graduation. So that was a nice gesture that they had. And a couple other families did the same thing. So it was neat to be a part of that experience for him. I currently work at the Missouri School of Dentistry and Oral Health. The photos you see here are of the campus that they have up in Kirksville, Missouri. So it's split between two campuses. They do their first 2 years in Kirksville, which is where Truman State University is, and the medical school is at. And then they do their second half of dental school, their 3rd and 4th years in downtown St. Louis, kind of near the Truman 44 kind of interchange in downtown St. Louis. That's the picture of the 3rd and 4th year clinic from the outside. And then, from the inside, it's beautiful. We've got all these brand new operatories, really nice state-of-the-art equipment, materials, supplies, all stuff brand new. So it's a really, really great place to go to school, I would imagine, for the students to teach. It's an awesome institution. I think it's neat in the sense that it's brand new, so it has a lot of potential for kind of carving its niche in the community. One of the things that I am passionate about, obviously, is taking care of head and neck cancer patients. And we've been fortunate on a couple accounts. We've recently been given about a $50,000 grant for taking care of folks. So, we're able to get them all ready to go for their head and neck cancer treatments prior to all their surgeries, radiation, chemotherapies, and whatnot. It's all free of charge for patients that are being referred to us predominantly from the SSM healthcare system. So a couple objectives today. I've basically broken this into 3 different parts. The first part's going to kind of talk about the epidemiology, the etiology of cancers. We'll go on and talk about the staging, the prognosis, medical management of both localized and advanced stage disease, and then also talk about what the dentist's role is in getting these patients ready for the various treatments that they're about to undergo for treatment and management of their cancer. So the first part, general cancer concepts and oral and oropharyngeal cancers. I think history is really interesting. It's exciting to me. So when you talk about this stuff, I think it's kind of neat to see that this isn't new. I mean, we've been dealing with cancer for long times. First pop quiz. Does anybody know who this is?
The father of medicine?
The father of medicine. Yeah, so who is the father of medicine? I'm going to take a stab at it. Hippocrates. Hippocrates. So Hippocrates is the father of medicine. And it's kind of interesting. So he, came up with this term cancer more or less. He talked about things like carcinos and carcinoma. And in Greek, these words are derived from, what it means, crab, essentially. And the idea behind that is, a crab, it has these extensions and claws and whatnot. And so when they saw cancer, they think about it spreading out throughout the body and kind of like a crab finger-like extension. Historically, you go back, it's 3000 BC in Egypt. And you can see that people have written about cancer, what was be our understanding of cancer at the time, but you'll see it documented where it's been stated as there is no treatment, there is no cure. You'll see evidence in the fossilization of mummies, actually, where there's evidence of head and neck cancers, where we've seen individuals that have had, growths that are suggestive of bone cancers, and even cancers that are suggestive of head and neck, we can see by the bony destruction of the skull and cranium and different vertebral bones. As far as for general cancer concepts, this is easy, simple stuff, but I think it's important to start off on the same page here. So cancer is obviously, it's a lot of different diseases, but it's all kind of categorized by abnormal cell development, which is leading to the uncontrollable cell growth, and then eventually these cells infiltrate, they invade, they destroy body tissue, and they lead to issues throughout the body. There's obviously different types of cancer. We're going to predominantly focus on carcinomas. That's what we'll see the most of as dentists, oral surgeons, different specialists and whatnot. But obviously you have your sarcomas, your lymphomas, your leukemias. There's all different types of cancers that individuals can be subjected to. So how does cancer kill? I think this is kind of an interesting concept, and it's something, you think, well, cancer kills people, that's obvious. Well, how does it do that? And essentially it does it by evading key organs, and it interferes with bodily functions. So when you think about it in a couple different ways, think of the digestive system, for example. So you have a tumor. That tumor is blocking the ability for food to pass and for nutrient absorption. That leads to malnutrition. You can't fight infections, and then consequently you die from this infection that your body doesn't have the energy to fight. If you have a cancer in your lungs, that leads to a potential collapse and an infection. You can't absorb enough oxygen. Your body weakens, and then you die. In terms of bones, for example, you have a tumor within the bone that leads to a calcium imbalance. That affects potentially the kidneys or the heart muscle function, and then you have complications from that and you die. Or even blood vessels, for example. You have damage, you throw a clot, it goes to your brain, you have a stroke, and you die. So there's lots of different ways in which cancer can kill. It's interesting to me to think that it's not always necessarily the site of which the cancer is located that's causing the issue, but sometimes the other effects within the body that's actually leading to the issue that we're dealing with. So statistically, cancers are going to account for about 1/4 of all the deaths in the United States. And what we're seeing is about 46% of men and 38% of women are going to develop cancer. What we're seeing also is that we're getting a little bit better at treating this. The amount of death rate has been decreasing for the past 10 years, so that's a positive note. African American men and women, again, minority populations are going to be a little bit more susceptible to morbidity and mortality issues associated with cancer. Also, they're more likely to present with an advanced stage disease at the time of diagnosis. And there's all kinds of different theories and rationales behind that. You can talk about access to care, you can talk about patient motivators for seeking treatment, but statistically this is what we're seeing. So as far as for head and neck cancer itself is concerned, I think it's important to kind of talk about the anatomy and some of those considerations. So we're all familiar, obviously, with the oral cavity, with the tongue, lips, gums, even part of the oral pharynx, obviously, but there's lots of other anatomical considerations. So especially as it relates to the pharynx, we're seeing a lot of pharyngeal cancers presenting, particularly with the rise of HPV cancers and whatnot. So you have obviously your nasopharynx, that's going to be from your skull base to the soft palate. The oral pharynx, like we're familiar with, is essentially the back of the mouth to the vallecula. And then you have your hypopharynx and larynx that are kind of rounding out the inferior portion of your pharyngeal space within the body. Additionally, anatomically, we're filled with lymph nodes. Second pop quiz would be, anybody want to take a stab at how many lymph nodes we have in the body? If you had to guess. Nobody. 6 to 700. So there's 6 to 700, and we have about 150 to 200 of these or so that are located within the head or neck region. And when you talk about lymph nodes, we have them described in a couple different ways. You have your superficial and deep nodes, and they're oftentimes referred to as cervical lymph nodes. So cervical lymph nodes are going to be the ones that are of predominant importance to us. Those are the ones that are located in the neck. Also anatomically, you have to consider the different areas of the neck as broken down into the lymph node levels that are based upon different surgical and anatomical landmarks. And when you're talking about these diseases, oftentimes the location of the disease or the extent of the disease is mentioned in terms of these various sections within the cervical neck portion of the mouth. So this is an important thing to consider or be able to reference when you're talking with or communicating with these surgeons so you can understand where these cancers are located at. It's also important to kind of talk about the differences between oral and head and neck cancer. So obviously the big umbrella is head and neck cancer, which is going to account for about 3% of all the cancers in the United States. Within that, though, obviously, is the subclassification of oral cancers. So these oftentimes get interchanged, and they really shouldn't. They're two different things. This leads to, as you'll see a little bit later in the presentation, is there's a lot of confusion over some of the statistics, the prognosis and whatnot, because people talk about these things interchangeably when they're really not the case necessarily. But it is important to remember that there is about a person every hour, every day of every year that's going to be diagnosed, that's going to pass away from this disease. So it's a prevalent disease that you will encounter and have encountered, obviously, throughout your careers. For head and neck cancers, the 5-year survival rate's about 57%. Historically, we've kind of hovered around this 50% mark. We are getting better, though. And I think it's interesting to note that this improvement, it's not necessarily because we're getting better at treating it per se, but because the etiology is starting to swing. So we're starting to see a higher prevalence of HPV-positive cancers rather than cancers that have been associated with your traditional etiologies like tobacco smoking or alcohol intake. You know, it's kind of sad in a sense. It's good in the sense that we're being able to have higher survival statistics, but it's not because we're doing better necessarily, but it's better in the sense that the disease etiology has changed on us. So on to oral cancer. So obviously this is not an exhaustive list. There's lots of different types of cancers that can present within the mouth, within the oral cavity. Again, predominantly we're going to be focusing on the squamous cell carcinomas. That's going to account for the largest portion of cancers that we're going to encounter as dentists and specialists taking care of oral health. But there are different types that you could potentially run into as well. This is what's called a verrucous carcinoma. And you see this and you think, oh my God, that looks terrible, that's awful. And in reality, this is slightly better. This is a little bit better than the patient that might present with a true squamous cell carcinoma. A verrucous carcinoma essentially is a lower grade variant of what a squamous cell carcinoma is. It's going to account for about 5% of all the cancers of the mouth or the oral cavity. It is invasive to nearby tissues, but it doesn't metastasize very well. So the good thing is that it looks gnarly, it looks bad, but it doesn't necessarily travel throughout the body. You're commonly going to see it in the mouth and the cheeks in those areas. And again, like I said, it looks bad, but in reality, it's a better diagnosis than a traditional squamous cell carcinoma for a patient. Oral melanomas are not common at all, but I think it's interesting to note some of the background about them. So a melanoma is obviously a cancer of a melanocyte. Those are the pigment-causing cells within our skin. And they're going to account for about 1% of all of the oral cancers that we see. As far as for the local sites that you'll commonly see these, it's going to be usually the hard palate. It's going to be the gingiva of the alveolus. And like you see here, this can be oftentimes confused with an amalgam tattoo, for example. So I think it's important to document these things well, talk about your amalgam tattoos, get these things sometimes consulted if they are changing on you on your repeated screenings and appointments that you're seeing your patients with. I think it's also interesting to note that the risk factors for a melanoma in the oral cavity are more or less unknown. We're still confused about this because if you think about a melanoma, you think skin cancer, right? And you think skin cancer, you think sun exposure. There's not a lot of sun in the roof of the mouth. So what is causing these to happen? There's a lot of research that's kind of developing in this area, and we're still unsure. So it's kind of an uncharted territory that needs some more work. There's also your minor salivary gland tumors. And when you talk about minor salivary gland tumors, you're talking about your adenoid cystic carcinomas. You're talking about your mucoepidermoid carcinomas and these varieties. And commonly you're going to see these in the roof of the mouth. That's the most common location. But remember, we do have minor salivary glands all throughout the oral cavity. You have them obviously in the lips, you have them in the tongue, you have them in the roof of the mouth, like in this case, you have them in the cheeks, in the larynx. They're all over the place. So, commonly the classic textbook presentation is going to be the roof of the mouth, but they can present in other parts of the oral cavity as well. You also have your lymphomas, and these are cancers that are going to develop in your lymphoid tissues. As far as for their presentation, you're normally going to see them in the base of the tongue, in your lingual tonsil area there. You're going to see them in the tonsillar pillar area associated with your palatine tonsils as well. There are your adenoid tissue. That's technically a lymphoid tissue as well. You can have cancers that arise in that particular area there. And usually these cancers are going to present within a node, right? So you think of a lymph cancer, you think of lymph nodes. Lymph nodes are going to be the most common presentation of these cancers, but they can also present extranodally, so that's outside of a node. And that's going to happen about 40% of the time or so. The other interesting thing is that they will present outside of the mouth, obviously, and another heavily populated area with lymph tissue is the GI tract. So you're going to see the most predominantly distribution of these cancers in the GI. So if you're thinking about lymphomas, think GI tract first, and then mouth, head, neck region. That's going to be your second spot. You can also have metastatic cancers, and these are cancers that present within the head and neck, but they're going to derive from another primary location. Keep in mind that a cancer that comes from a different site is still going to be referenced as a cancer from that area. So this particular individual, they had a cancer that was coming from a adenocarcinoma of the colon. So they had a primary site in the colon. This cancer metastasized, and you can see it presenting as this kind of lucent lesion in the right mandibular body right there. So some of us look at this and we think, maybe that's just kind of orientation issue. Maybe it's nothing significant. But this is where it comes to become very important, where a good history of a patient is absolutely critical, because this might tip you off to say, hey, there is something potentially going on here. Let's consult with the physician. Let's consult with the past treating surgeon. Let's talk about this with the medical provider, because this might be something that's a little bit more malignant and concerning than just a positioning issue or whatnot. So we'll focus predominantly on squamous cell carcinomas within the mouth, because that's what we're going to see approximately 94% of the time. And again, these are cancers that are going to start in the epithelial tissue, which is that outer lining of tissue. And they're most oftentimes in our field going to occur within the tongue, the floor of the mouth, the lateral border, the posterior tongue. Those are all the classic things that we've been trained to look for. But also we can see them in the tonsils, in the oropharynx, and then within the gingiva as well. The average age of diagnosis for an individual presenting with the oral squamous cell carcinoma is 62 years old, but it can skew a little bit younger even. We talk about a fourth of them occurring in patients under 55. Males are going to suffer from these cancers more readily than females. And again, we see that minority populations are going to encounter these cancers more readily as well. As you get older, you're obviously going to be more likely to develop one of these cancers, right? You've been exposed to a potential etiological source. You're accumulating exposures and whatnot, but it's going to peak at about 60 or 70 years old for individuals. As far as etiologies, we all know the common ones, and the common ones include obviously tobacco smoking. And for tobacco smoking, what we see is that people that are using tobacco and smoking cigarettes and whatnot, their predisposition to developing an oral cancer is about 2 to 3 times that of somebody that's not. We do see a little bit of an increased risk with pipe and cigar smoking, and the theory behind that is that they burn hotter, they're a little bit more caustic, a little bit more damaging to the oral environment, and can cause a little bit more of an issue. It's important to note that these are all relatively risk to the dose, right? So the person that smokes for 20 years but only smokes a cigarette or 2 a day is not at as high of a risk as the individual that smokes a pack a day for 20 years. So the more you smoke in both quantity and duration is going to be worse for you. Smokeless tobacco, this is kind of a taboo area, right? American Cancer Association, whatnot, tobacco is bad, it's going to kill you, it's going to cause cancer and whatnot. But what we're seeing, though, as far as smokeless tobacco is concerned, as the types that we use in Europe and the United States, is it carries a lower risk of oral cancer. It's not as bad. Obviously, this is dependent, though, on the type of product. So the classic consideration you hear about is kind of the Eastern Asian areas where they're using betel quid and whatnot. But if you compare this to dip or chew or snus, those are technically a little bit of a less of a concern for the development of a cancer. The trouble that we have with this, though, is that it's difficult to isolate smokeless tobacco. So when you talk about somebody's cancer risk with the smokeless tobacco, usually that individual is they're also smoking cigarettes, or they're also drinking as well. So it's tough to isolate true smokeless tobacco as an etiology versus some of these other issues that also play a role. Alcohol, again, alcohol is another kind of a taboo area. What we do know with alcohol is that when it's used synergistically with tobacco, that's the worst case scenario. We don't want alcohol and tobacco combined. Alcohol consumption in its own right, though, that's where it gets to be a bit of a dispute. We do know that alcohol, when broken down by the bacteria in our mouth, it's broken down into various carcinogenic components. But there are also these huge studies that look at people that have used alcohol-containing mouth rinses, think Listerine and whatnot, where it doesn't appear to increase oral cancer risk. So this is kind of an up for debate topic, but what we do know is that when you use alcohol in conjunction with heavy tobacco use, that's when we see our worst outcomes there. There's also some interesting, least common etiologies that I think are just kind of fun to talk about and include. So iron deficiency is one of those. When you talk about iron deficiency, we're not talking about the person that normally has 5 hamburgers but only had 4. We're talking about the person that is severely deficient. But what happens is that we see that the normal repair, the normal development of epithelial cells within the digestive tract is impaired because the person does not have the appropriate level of iron. And so these cells, they're turning over rapidly. You're getting these mature cells that are not developed, and they're turning over and over, and they're immature, and they get damaged, and this happens in a cascade. And essentially, you have more cellular work that's happening where eventually it leads to a higher predisposition for the development of a cancer in presence of some of these other etiologies like like tobaccos and alcohol. Vitamin A deficiency is another thing. Vitamin A is important for the development of the appropriate level of keratin within the cell. If you don't have the appropriate amount of vitamin A, again, that cell is not developing the appropriate way. It doesn't have the appropriate defense mechanisms to some of these caustic etiologies, your tobaccos, your alcohols, and so therefore your cell can't defend itself. It turns over more rapidly, and you're setting yourself up for an environment where this can occur. Syphilis, right? We don't deal with this very much anymore because we have antibiotics and they work. But tertiary syphilis is actually associated with the development of squamous cell carcinomas within the tongue. It's kind of interesting to think about. We used to treat syphilis with a lot of heavy metals and arsenic and whatnot, and these things themselves are obviously associated with the development of cancer. So a lot of this is obviously historic, but it's kind of interesting to think about the way in which some of these weird diseases can impact the development of cancer. Immunosuppression is another big issue. So you think about somebody that is extremely immunocompromised through either HIV or AIDS. They have had an organ transplant, for example, and they're intentionally immunocompromised. These individuals have a little bit of a higher predisposition for the development of cancers. You'll notice on the etiology part, I left out HPV-positive cancers, and that's not because they don't play a role. It's because they play such a large role. I think it's important to talk about them in their own right. With HPV, essentially that's what is called a human papilloma virus, and it is now the most common STI or STD in the United States. There's over 100 types of those, and about 40 of those are going to be spread through sexual contact to the mouth area, through the genital areas, obviously. 40 of those can play a role in what we do on a daily basis. Virtually everybody is going to be exposed to HPV. Luckily for us, most are going to clear this issue. They're going to get rid of the infection, and it's never going to really develop into some of these complications that we really get concerned about. Males are more likely to develop an oropharyngeal cancer relative to HPV at a clip of about 4 to 1. So men are much more at risk for the development of HPV-positive cancers in the oropharyngeal area. And again, this is the fastest growing etiology for cancers of the oral and oropharyngeal area in people that are your atypical or non-traditional individuals that have cancer. So you mostly are thinking, hey, this is an older gentleman, he smoked forever, he drinks a 6-pack every night. That's not what we're seeing. We're seeing it starting to trend down towards a younger population where it's not quite that person anymore, it's your younger individuals. There's obviously all those different types of HPV. We predominantly get concerned about a few of them. The high-risk ones in particular are type 16 and type 18. Those are the ones that are going to potentially develop into your squamous cell carcinomas or contribute to the development of your squamous cell carcinomas. You have type 6 and type 11, and these are the ones that are associated with the squamous papilloma, right? You look in the mouth, you see this papilloma, and you think, oh, that's not normal. What's going on with that? It's an HPV strain, obviously. The good thing, though, to keep in mind is that that papilloma, it's not going to develop into a cancer, right? It's not like that is the thing that we need to be leery about. Obviously, there's needs for consideration for consultation, diagnosis, biopsy, and confirmation of that diagnosis. But don't think, oh my God, there's this big bump there. That's going to turn into a tumor and you're going to die. No, it's a different strain. So we're looking at those things, and obviously there's a need for consultation and diagnosis, but that's not what we're concerned about. We're concerned about the different types that don't present that way. They present, kind of these ulcerative, precancerous things and develop to these true cancers. This has obviously been in the news a lot. Michael Douglas came out and really talked about this, and in New York Times or New York Post, sex gave me cancer, right? So I think it's becoming less of a taboo topic that, yes, this is a means of communication of a virus that is very much associated with the development of cancer. And personally, I'm glad to see this, kind of becoming more mainstream. As far as vaccinations are concerned, a couple neat developments have occurred. So we used to have the traditional Gardasil vaccine, and we've now advanced to the Gardasil 9. And Gardasil 9 protects against about 9 strains, or it does protect against 9 strains of HPV. Recently, it has been approved by the FDA to work for both men and women up to the age of 45. So that used to cap out at about the 26, 27 range. But now they've said, hey, this is effective, this is going to be eligible for men even, and we're going to increase the range. This gets goofy, so when you talk about this with patients, the CDC has a little bit of a different take on this right now. So you talk about recommending vaccination to a potential patient or to the parent of a son or daughter of a patient, and they might not always get the same type of insurance coverage, right? Insurance coverage is for sure going to lag behind because the CDC is not giving us the same type of credibility for this vaccine as what the FDA is at this time. So I'm hopeful that eventually that's going to change and we're going to be able to get this vaccination in a lot more people. As far as your occupational exposure is concerned, I think that that's something that we're going to see more and more information come out about. There have been some studies that have been performed, particularly with, people do this as a profession, but urogenital, anogenital surgeries, right? And so those people are traditionally using a lot of, lasers and whatnot now. And so with those lasers, they're ablating these lesions. Those lesions are smoking and causing smoke. And what we're seeing is a little bit higher of a prevalence of HPV presentation as well as HPV positive cancers in these individuals. It's not drastic, but we're starting to see that there might be a little bit of an issue with an occupational exposure. So, I can't say this with certainty with literature to back it up, but if you're considering cutting these things out in your office with just a laser and whatnot, it's important that you're using the appropriate types of respiratory equipment and whatnot, because we're starting to see that this might potentially be a occupational exposure issue. The other thing that we're looking into with the vaccinations is how does this relate to an already exposed person's potential for developing a cancer of the head and neck. So obviously, if you've been exposed already, this vaccine isn't necessarily going to do what you want it to do. It's not going to protect you from getting it. But what does it mean for somebody that has already been exposed, has HPV within their body, but has not developed a head and neck cancer? Is the vaccine going to be hopefully preventative or proactive in avoiding development of a cancer? We don't know that yet. That's something that's hopefully coming down the pipeline. So when we talk about head and neck cancers, it's important to know about the staging and obviously the medical management, just so that you know what these patients are going through and what they are going to be going through, so that not only can you kind of consult them, but so that you can plan most effectively for the care that you're going to provide these individuals. And one of the ways in which we do that staging is through a TNM system, which is going to talk about the tumor, the nodal involvement, and then the metastasis of that cancer. So again, tumor, that's going to relate to the size of the primary tumor. Obviously, bigger cancers, bigger tumors are bad. It's like golf. You want lower numbers. That's good. N is going to refer to the lymph nodes, and that's going to be talking about, is a lymph node or are lymph nodes involved, and to what extent? Are we seeing them on one side of the neck versus on both sides, or one side versus the contralateral side. Metastasis, obviously, where's the cancer gone to throughout the body? Those are all important things when we talk about the staging and the prognosis for an individual. Staging essentially is going to come down to a couple of different topics. When we're talking about staging, the surgeon, the people that are involved in the care of this individual for the treatment planning, they're going to look at, obviously, the physical examination. Where is the tumor? Can I see it with my eyes? Did I do an endoscopy to determine where this cancer is located at? Biopsy, a biopsy, be it a direct biopsy where you cut a piece of tissue out. Could it be a fine needle aspiration? There's various types of biopsy, but a biopsy is important for a histological confirmation of a diagnosis. Imaging as well, and obviously there's lots of different types of imaging. CT scans are a real workhorse in terms of the imaging for the diagnosis and treatment planning for cancers. CT refers to computerized tomography, and basically this is a series of x-rays that are taken from different angles throughout the body. A computer processes this and it turns it into a 3D image that we then use for the determination of the location of the cancer. This is what a medical CT scanner looks like. Now it's nice, it's a little bit more open-aired, but a patient slides inside of that, and basically they get a bunch of x-rays taken from a lot of different orientations, and a really, really smart person came up with the computer program that's able to put that into a three-dimensional design so that we can look at it, manipulate it, and see where these cancers are located at. When you look at a CT image, obviously there's different cuts you traditionally see. The first one's going to be your sagittal. The other two are going to be your axial cuts. And what you're looking at in this case is a tumor of the tonsils and the soft palate, and that's what the white arrows there are representing. So on that first picture you see, that's a pretty big tumor, right? That's sitting in the soft palate. It's extending into the oropharynx. That's something that's obviously easily detectable with your eyes for a clinical exam, but you need to have your diagnosis obviously confirmed through multiple modalities, including the imaging. As far as additional imaging techniques, we have MRI at our disposal. And MRI is a magnetic resonance imaging. And what this does is it uses a magnetic field and radio waves to produce an image. So in the same way we talked about taking all these images and basically creating a three-dimensional projection, we can do the same thing with MRI. And it allows for us to visualize tissues a little bit more better, soft tissues and whatnot. Traditionally, your CT is going to be better for your bony tissues, hard tissues and whatnot. Your MRI, you can see, is a little bit better for the soft tissues. So when you look at this picture, what you're looking at again is the axial slice, and you can see that this person has a left lateral tongue cancer that has kind of been determined through that line that you can see that's measuring that gross tumor volume on the left side of this patient's tongue. And you'll notice that you can see much better in much better detail the soft tissue, obviously, than you could on those CT scans. Another type of image that you'll often see is a chest x-ray. And you're thinking, why a chest x-ray? We're dealing with the mouth or the oral pharynx. Well, what we're looking for is if the cancer is spread to the lungs. So this individual, they had a prostate cancer, actually. They didn't have an oral cancer. But this prostate cancer, over the course of a year, you can see between the two, has metastasized to the lungs and has significantly grown in size. So not a great prognosis for this individual, unfortunately. PET scans are really interesting, and if you haven't seen PET scans before, I think they're fascinating images to look at. PET scan, what that stands for is a positron emission tomography, and what they do is a tracer is basically put into the body, and this tracer is oftentimes tagged to glucose, and what we're looking for is the presence of cellular metabolism, right? So metabolism is very much dependent upon glucose. That's obviously an energy source, and what this is going to help us identify is not only the location of the cancer, but if there's potential spread of the cancer or a potential recurrence. And when you look at a PET scan, oftentimes these images will be overlying either a MRI or a CT. So in this individual, you have a PET scan that's overlying an MRI. And you can see some areas that are quote-unquote hotspots. So hotspots are those areas of high metabolic activity. So the brain is going to be one of those. The brain's going to really light up. You can see where the word hotspot comes from. It's kind of glaringly obvious that that's an area of high activity. This individual happens to be suffering from a pituitary tumor, so that's where that arrow is pointing to. And what you see there is that the primary tumor site is very much lit up like a little golf ball. You'll also see these images, and when you look at it, you'll look in the groin area. So the bladder is going to light up too, because obviously as this tracer goes throughout the body, it has to accumulate somewhere and get excreted. So you'll oftentimes see the kidneys and the bladders light up too. So this is helpful, obviously, for combining these different modalities and very much seeing where this tumor is at. I think when you compare it to a CT, for example, you look at the image on the left, and if you're not used to looking at CTs, you look at this and say, oh, I see a lot of stuff. There's probably a vertebra in there. I don't necessarily know where the cancer is. But when you combine this with a PET scan, it becomes obvious, right? You see that tongue is infected. You also see nodal metastasis, where otherwise that was very tough to see to an untrained eye. Again, same individual here. That node is not as obvious on a CT scan, but when you combine it with a PET scan, you can see that node light up like Christmas. So this is a very important diagnostic aid that you can combine with your different imaging modalities to very much hone in on where these tumors are located at. As far as staging is concerned, we're going to go through a very, very, very simplified version. So staging is very dependent upon a couple different things. Where is the disease located, the extent of the disease, and if the disease has spread. And it's very specific to the area of the body that you're dealing with, right? So I'm going to kind of lump it together with oral and head and neck cancers and whatnot, but it gets very specific to a tonsillar cancer versus a tongue cancer versus a pituitary cancer. And this is kind of a very simple version of it, but it gives us an idea of how staging increases and prognosis decreases accompanying that. So a stage 0 cancer is a carcinoma in situ, and what that is basically it's a cancer that's only found where it began in the squamous cells very superficially. It hasn't invaded anything yet, and at this stage what is commonly going to happen is a surgical treatment of this cancer, right? Assuming it's surgically accessible, we're going to cut that out and we're going to monitor it. A stage 1 cancer, what we're seeing is that this cancer is getting a little bit bigger. The tumor is getting a little bit bigger in size. But it hasn't yet spread to different parts of the body. It hasn't spread to the lymph nodes. We still see it's in its primary location, but it's gotten a little bit bigger. At this stage, you're usually going to get surgery and you're going to consider radiation therapy. Stage 2, this cancer, again, it's getting a little bit bigger. It's also getting a little bit deeper, so it's becoming a little bit more invasive of the underlying tissues relative to where the primary tumor is located at. It hasn't invaded into the lymph nodes. It hasn't gone elsewhere in the body, but it definitely has gotten bigger, and it definitely has gotten a little bit deeper into the surrounding areas. Stage 3, this is where it gets kind of weird. So there's a lot of different pathways in which you can go. The first of the two, essentially, is that the cancer has grown bigger, it's grown deeper, but it still hasn't gone into the lymph nodes. So it's big enough where it's not a stage 2 anymore, it's deep enough where it's not a stage 2 anymore, but it still hasn't gone anywhere. Or you can take a step back and say, hey, this tumor, this site is still relatively small, but what we're seeing is that it has gotten into a lymph node. And so the key takeaway in this is that essentially nodal involvement of a cancer is going to jump the staging up to at least a stage 3. As you move along to stage 4 is going to be broken down into 3 different sections, A, B, and C. And again, they're getting worse as you progress through the alphabet. So a stage 4A cancer, that's where the cancer is going to be completely kind of invaded into those underlying tissues. You're going to see it into areas of bone, nerve, cartilage, some of those areas. And you're going to see potentially it spread into the lymph node on the same side as where the tumor exists. So if you have a cancer that's predominantly located on the left lateral tongue, if we see a nodal involvement on the left kind of cervical area, that's what we're thinking about there. Also, it could be invasive, but we're seeing it spread into either multiple nodes on the same side, or that cancer has jumped to the other side, gone to the contralateral lymph nodes. So essentially, the key takeaway here is that increased size, bad, nodal involvement, bad, but in particular with this, once we start seeing more nodes involved, or we start seeing the contralateral side involved, that's where we're jumping up into the different stage 4 cancers. Stage 4B, again, it's getting bigger and bigger and bigger. We're potentially involving major structures at this point. So this is your skull base, this is your aorta, or the carotid arteries and whatnot. These are areas where you definitely don't want a cancer to be. Or, again, we're seeing it spreading to more larger lymph nodes. We're getting a lot more lymph node involvement. So, again, increased size, increased nodal involvement, all bad things. It's going to escalate the stage. Finally, with the stage 4C cancer, this is where we're seeing metastasis. So metastasis is kind of the very, very, granddaddy, bad news. We don't want to see metastasis to other parts of the body. Generally, these are very, very, very tough cancers to treat. and whatnot, where sometimes the recommended means of managing is going to be more palliative for these individuals. So how does staging play into prognosis? I'm kind of nerdy, I guess, with some of this stuff and some of the epidemiological studies that have gone on, so I'll kind of dig into this a little bit, but essentially, your prognosis is going to vary by your location. The thing you have to consider is that, what we're doing is here, we're combining all the stages, and we're combining all these cancers, and we're talking about a relative survival. And these statistics can be a little bit misleading for a couple things. One of the issues that we're seeing is that we talk about staging, but we're focusing on the staging at diagnosis and not necessarily the staging at death, right? So obviously that cancer has the possibility of progressing in stage. When you talk about, the percent of cases, the presentation of them, it's tough to talk about, well, they presented with a 2, but they escalated to a 4A, so what are we calling that cancer relative to breaking it down amongst the other types? They also don't take into account patient health, right? So an older individual, when you talk about a prognosis, their prognosis is going to be worse, right? They have more morbidities associated with them. They might be diabetic. They might have had multiple heart complications and whatnot. That person is less resilient to a cancer versus your 25-year-old young lady that has an HPV-positive cancer. So prognosis is going to drastically be different between those two individuals. The other thing is that a lot of this information hasn't really taken into account the HPV confirmation within the diagnosis. So the prognosis, a lot of our historical data on prognosis is dependent upon these huge databases of information, but HPV is still relatively new. So HPV is definitely kind of skewing our understanding of what the prognosis is for these individuals. Overall, when we talk about the 5-year survival of a patient with an oropharyngeal cancer, you're talking about 64, 65% or so. And again, remember I talked about earlier with an oral cancer, that's about 57%. So again, these things get used interchangeably, but we're in that 50 to 60, that kind of ballpark area. Not terrible, but also not great. Obviously, as you progress in your staging and whatnot, that's going to differ in terms of what your prognosis is. And the National Institute of Health, for whatever reason, the database that they use through what's called the SEER database, essentially they broke it down a little bit differently than what you commonly see presented in literature. So we talked about stages being 1 through 4. They break it down through localized, regional, distant disease. So it gets a little bit screwy in terms of what the true prognosis is, but essentially, you get further along into the progression, into the staging, into the presentation of that individual with a worse staging, and their prognosis is going to drop down. It's also important to know that this is talking about relative survival. So we're not talking about out of all people that get diagnosed, for example, with a tongue cancer, that in 5 years, if it's a stage 1, 84% of them are going to be alive. That's not what this is saying. What this is saying is that compared to a healthy individual that does not have cancer, this person that does have cancer, their relative survival rate compared to an otherwise healthy person is going to be 84% in our example given. So that's an important thing to keep in mind when you're talking about prognosis. So what do we do? How do we treat these diseases, or more importantly, I guess, how do our medical colleagues treat these diseases? And I've kind of broken it down from a localized early stage disease also into a more advanced, regionally advanced disease. We'll start off with the localized version. With the localized version, we're going to see about 30 to 40% of patients presenting in this variety. And in general, these patients are going to either have primary surgery with intent to treat, or they're going to have definitive radiation therapy. And the choice of therapy is going to be based on a couple things. The site of the cancer, the big thing with that is it surgically accessible? Can Rob get in there and cut it out versus, hey, I can't reach that. That's way down, near the larynx. That's tough to get to with my hand. I obviously can't stick my hand down there. That's tough to do. Also, we want to talk about the functional outcomes and the morbidity associated with that. So if you've got a cancer of the vocal cords, for example, do you want to do a laryngectomy with this individual? Hopefully not, if you can treat it with radiation instead. If you can treat it that way, hopefully we can preserve some of these vital organ functions and maintain that individual's ability to speak. So, very much so, where is this tumor located? That's going to help make up our decision. Obviously, oral cancers are going to be more accessible. We're more likely to treat those surgically. In terms of the surgery, there's a couple different ways to go about it. There's a traditional access where you make a wide local excision, but we also now have transoral lasers and we have transoral robotics, and we'll talk about that here in the next slide. But most oral cavity cancers are going to be treated transorally, so through the mouth. We're going to reach our hand in there, or we're going to use an instrument to reach in here. This is an example of a transoral laser, and what you see here is a surgeon that's sitting there, and they've basically got straight line access, and they're going down, in this case, down to the vocal cord. And so the surgeon sits there, they're manipulating a laser, and they're controlling it with a foot pedal, essentially, to go in there and ablate where this tumor is located at. And so what you see here, for example, post-operatively, this is about 18 months or so, you see a person that presented with a vocal fold cancer that now has had great results. And the nice thing about this is you treated this with very little morbidity, right? You're not cutting this person open. You're not blasting them with radiation. You're not taking away their ability to speak. This is a huge, huge, huge treatment modality that can be very beneficial for patients that are in these types of situations. A transoral robotic surgery, these are super intriguing to me as well. Basically, you have a surgeon that sits there and plays a video game, right? The patient, unfortunately, you see, it's hard to see actually, but their mouth is right there. And they essentially have all these spider-like projections of these robotic arms that are extending into the oral cavity, into the back of the throat, different elements of these attachments that can bend and go different directions that it's very hard to fit a scalpel blade or a hand into, that we can fit a robotic arm into and have that manipulated by a surgeon there. And so you'll see, obviously, there's a lot of prep time to get these patients on the table and treated. But again, where you might have had to go through a very, very, very morbid surgery where you cut this person's mouth in half essentially and open them up like a door, you can now treat this with essentially robotic arms that can get to these sites and cut that cancer out and drastically improve this patient's post-operative healing, function, aesthetics, and whatnot. So as far as radiotherapy is concerned, that's what we're talking about with radiation treatments and whatnot. So radiation is obviously a great modality. It's an awesome thing to have in our armamentarium for the treatment of these diseases. And when we talk about radiotherapy, there's two important concepts to keep in mind. We have what is called intensity modulated radiation therapy and image-guided radiation therapy. And essentially what we're doing is we're taking images of the patient and we're planning out how this radiation can get to the gross tumor volume effectively with minimizing the various different complications that can come with just blasting somebody with radiation, indiscriminate of the different structures in the area. Another interesting development that we're seeing is what's called proton therapy. And when you talk about radiation, X-rays versus protons, they behave very, very differently. So radiation, classically, the simple concept is you just blast it, right? And it's one strength and it's consistent throughout its dosage. Protons work a little bit differently, right? They are able to change their intensities. Think of a sinusoidal wave, it goes up and down, right? So there's areas of low intensity, there's areas of high intensity. So if we can specifically target that proton to hit the tumor at an area of high intensity, that is very effective for us because we can get the maximum dose to the area while at the same time minimizing the intensity that the surrounding areas in that person's head and neck area is exposed to. So we can avoid things receiving a high dose like your parotid glands, like your various salivary glands, like the larynx, like the brainstem, for example, very important structures that we want to try to protect. There's also post-operative radiotherapy. So this is radiation therapy that's given to a patient after they've had another treatment modality in place. And this is oftentimes going to be indicated for, more regionally advanced diseases. It's going to be if we have a surgery that's done, but we see a margin that's, it's positive we didn't get all the cancer out or it's close, or if they have other recurrence risk factors, which would include things like lymphovascular invasion, or if you've got perineural invasion. If you've got a patient with these risk factors, we're probably going to consider radiating you after the surgery as well. As far as for your advanced diseases, we're going to see people present with these about 60 to 70% of the time. And these are your stage 3 and 4 diseases. These are, again, going to be associated with a higher risk of recurrence and metastasis. And usually what you're going to see is more of a combined modality approach. We're going to be doing surgery, radiation, potentially chemotherapy as well to treat these individuals. And again, this can be broken down a couple different ways. Primary surgery, we're going to cut it out and be done with it. We're going to potentially induce with chemo. We're going to start with that. We're going to shrink the tumor down, and then we're going to cut it out. Maybe we're going to do chemoradiation and not do any kind of cutting. Or maybe we'll sequentially do it where we induce with chemo to shrink it down to better target it, and then we come in with our heavy hitters and really blast it with radiation. So, classically, you talk about, a surgical approach, and like we were showing before with some of the advancements with robotics, with lasers and whatnot, an individual that might present with a surgery that needs to be performed manually with blade, scalpel, whatnot, you'll see very, very morbid issues with these individuals. So, this is a lip split mandibulotomy. This person essentially is going to have their mandible split in half, and they're going to be opened up. So you can see how essentially they've opened up the lateral side of the face so that they can access, a tumor that had been, predominantly involving the gingiva adjacent to those, the buccal portion of those molars, but it had metastasized and had invaded deeper into deeper structures that had to be treated surgically. So when you look at this picture, comparing this surgical access to the potential for the use of a robot or the use of a laser, obviously, if you can treat it with some of these different modalities, that is hugely beneficial, not only to the patient's functional outcome, but the aesthetics obviously as well. This particular individual, they had a scapular graft placed. You see a titanium plating in there. The neat thing that we're doing now is we're able to put implants into these, right? So we can essentially provide a vascular blood supply to these grafts. So this particular person had a graft taken from the scapula. It was moved up into the mandible. It was plated in place. They anastomose, the vasculature with, usually the facial artery or whatnot. It gives that bone a vital blood supply. Then we can sink implants into it and rehabilitate this person. And this can all be done, believe it or not, through three-dimensional reconstruction. This can all be planned out preoperatively. So this person walks into the hospital, they get this surgery performed, and they can, in some cases, walk out with teeth. That's crazy to think that we're able to do that, but that's where we're at right now. As far as for the management of the neck, there's a couple things to consider, right? We talked about those different lymph nodes. So what we're talking about with lymph nodes is, do we need to remove those? If the neck is involved, if we're seeing nodal involvement, that's going to really tip the scales in favor of performing a surgery to get those nodes out. In some cases, if we're more concerned about the probable invasion, or the person, like we talked about, had some of those risk factors, neck dissection is going to be considered. This can be done in a couple different ways. There can be a more selective neck dissection where we're just focusing on a certain region of the neck. So if you remember that slide that we had before with the different numbers, 2A, 3B, whatnot, we can hone in on a particular site, incorporate the nodes that were involved, selectively take those out, and be a lot less invasive than this, for example, which is a radical neck dissection, which is where we're removing, virtually all of the cervical lymph nodes in this individual. In terms of radiation therapy, a couple different principles. So radiation, essentially how it works is it imparts energy into the tissues, and what this energy does is it generates free radicals that damages the DNA. Your cells can't reproduce as much, and that's good for a cancer, right? Because that tumor is growing uncontrollably. So if we can keep it from growing, that's what we're looking for. You'll see that this is measured in what are called grays, and it works on the metric system. So you'll commonly see it measured in grays or centigrays. When it comes to the intensity modulated radiation, these are going to be non-uniform beams. So we talked about that initial blast. That blast is as strong here as it is here. We now have ways to kind of change the intensity relative to where the cancer is and the target that we're trying to hit. And so we want to selectively shoot that target with the right amount of cancer right amount of radiation while minimizing the exposure in other parts of the head or neck area. And we do this by essentially having the radiation move around the individual's head. So what you see here is a patient on a table. That radiation instrument is moving around their head, and maybe in this orientation it's blasting them with 50 gray, but in this orientation it's hitting them with 1,000 gray. And what we're seeing is maybe I can be a little bit, my depth of penetrance is better here, but it's a little bit less so here, but I want that because I want to protect the brain, but I still need to get to a little bit of the tumor that I can't get to it without, really cooking them from this direction. So it's a way in which we can shoot a little bit more from one orientation, a little bit less from another orientation, and basically target that cancer a lot more accurately with minimizing exposure elsewhere. The patient essentially is going to be strapped down to a table, and it's not fun. They have what's called a mask made, a radiation mask or a SIM mask. You'll see it referenced in a lot of different ways. But essentially what we're doing here is we're keeping this patient locked into place. So if you think from the radiation oncologist perspective, they've planned this very detailed and articulate plan to very selectively target this cancer. The last thing that you want is for this individual to show up one day and have this orientation, the next day to have this orientation, the next day to be like this. You want to lock them into place more or less. And so you can see why patients don't enjoy this. They're strapped to a table while they get blasted with radiation. It's I don't know the right word for it. You'll see kids that have head and neck cancers, for example, and one of the fun things they do to help children cope with this is they'll turn this into a superhero mask, for example. So this will be a Batman mask, or it'll turn into Superman. And it's kind of neat to see the ways in which these physicians are trying to help patients kind of cope with the fact that they're essentially strapped to a table and getting blasted with radiation. Chemotherapy, we won't touch too much onto this, but essentially you're talking about some common agents which are going to include your platinum-based medications. You're going to talk about your fluoropyramides, those types of medications. And generally, we can see these either taken by mouth, you can take them intravascularly, and they can be used individually. They can also be used in conjunction as well. So a common conjunctive medication that you'll see is cisplatin with 5-fluorouracil. And what we want to see is that we can shrink this tumor through the chemotherapy and then maybe more selectively cut it out, maybe more selectively blast it with radiation. We oftentimes see these given in cycles, right? So they'll have it for a couple weeks, they'll get some downtime, and then they'll come back again and get more of the chemotherapy treatment. So now to, I guess, the reason why we're all here. So what do we do? What are some of the considerations that we have to have in mind when we're developing a plan for these individuals relative to what they are going through, what they are about to go through? How can we best facilitate a healthy oral environment that is going to be at the least amount of risk for some of the post-operative complications that we see with these individuals? So in terms of a referral, I think it's key to have a couple different items included in this. Obviously, I want to know the cancer type. I want to know where it's at, and I want to know the staging. That's going to help me identify a couple different things in terms of what I need to do for this individual. I also want to know, are we doing surgery? Are we doing chemo? Are we doing radiation therapy? That's going to affect my timeline because oftentimes, when you see these referrals from a doctor, they want the dental work done yesterday, right? So it's not fair necessarily to say, yeah, well, we'll get them on the book in 2 weeks, because in 2 weeks they've already been through several rounds of radiation or chemotherapy, or they're sitting in the hospital recovering from a surgery at this point. So you have to get these people expedited and get them going. So the more information that you have and are able to procure, you're better able to plan your treatment. I also want to know the prognosis and the goals of the cancer treatment. So not to sound too morbid, but I want to know, are we trying to cure this person, or are we trying to make them feel better as they progress into that next phase in life? And the idea behind that is, well, maybe I'm not going to take out all of your teeth if I know we're just treating you to make you feel a little bit more comfortable, right? There's a lot to say for being able to eat hamburgers and pizza and chicken wings on your way out versus totally edentulating somebody that has a very, very, very poor prognosis for survival. That's something you need to take into consideration as well. I also want to know their medical history, obviously the medications, and then the timeline like we discussed earlier. And usually what you'll see is you'll get a referral and they'll say, hey, we want this done ASAP, which means now, which means if you could have done it yesterday, the week earlier, that would have been great. You have to remember that these people, they're getting thrown a ton of information, right? So they're seeing a medical oncologist, they're seeing a surgeon, they're seeing a radiation oncologist, they're seeing potentially a speech pathologist and a nutritionist. So their day is just filled with appointments and talking to social workers and just trying to keep it straight. So anything that we can do to make their lives easier and try to be accommodating to their schedule is going to be immensely appreciated by individuals that are going through this process. In terms of the different components of the examination, obviously extraorally, I know that this person has cancer already. So I don't necessarily need to know, hey, this is cancer, right? I know that they have it. What I'm looking for more so is where is the location relative to what I want to do restoratively, and what is the extent of it, right? So if they have, a large tumor that's going to involve a significant portion of the mandible, that's going to change my ability to consider making a denture for this person versus the individual that might have just a small localized lip cancer, for example. I'm also seeing how this impacts the patient's ability to open, right? So lots of complications from the different treatment techniques. Surgery, particular radiation therapy, is going to lead to scarring and fibrosis of the tissues, right? That is going to impact a patient's ability to open and close, and it's going to impact their ability to fit a prosthetic into their mouth. So if you've got a patient that has had significant radiation therapy, significant surgery, and they can't open, maybe you can't plan to open up their VDO with this big, glorious denture because they just simply can't get it in there. So you have to think about these different concepts. Intraorally, basically it boils down to a couple things. It boils down to periodontal condition. It boils down to cavities, caries, if they have any sources of odontogenic infection, what the restorability of the teeth are, and again, then what the maintenance possibilities are. And what we're trying to answer essentially is, if we're trying to preserve teeth, if we're trying to avoid extraction in this patient, can we ensure that this tooth is going to be maintainable, salvageable, and treatable for the rest of this patient's life? A lot of this information that I'll talk about here is based out of a huge study that was performed out of a hospital in New York City called Memorial Sloan Kettering. They happen to have a really great fellowship program for head and neck cancer dentists and whatnot. And so they did a huge study. They looked at about, I want to say it was about 1,200 patients or so. And essentially what they were looking at is our approach to handling these patients, is it effective in preventing the big bad deal of osteoradionecrosis? And what they were seeing was that their patients were developing osteoradionecrosis at about a rate of 1% or so, right? Which, when you look in the literature, the traditional studies are going to show you that people will develop osteoradionecrosis on extractions post-radiation therapy about 7, 8, 9, 10, 15% of the time. That's kind of the range that we're dealing with. So what they were doing is obviously working. So a lot of these suggestions and recommendations are coming out of a huge study that has a lot of validity to it. Periodontal disease. So we talked about this. 1 out of every 2 American adults over 30 has gum disease. And that gets worse as we get older, obviously. 65 or older, the prevalence jumps up to 70%. So you have to think about pocketing in these individuals and whatnot. Generally, what we're seeing is, what is somebody's compliance with, not only receiving the initial therapy, but then also on their maintenance schedule and whatnot. So that's where, in the patient's ability to take care of themselves and the ability to present for maintenance appointments is very important. Keep in mind that these patients, they've had their tongue cut out, they've been blasted with radiation. It doesn't feel good to floss anymore. So, you talk about somebody that's presenting with periodontal disease, the likelihood that they are going to improve upon their compliance, improve upon their hygiene is not that great. I showed this slide to our medical colleagues, and they find this fascinating because we look at this and we say, okay, obviously we interpret the radiographs and we see, yeah, these lesions are obviously various levels of intensity, but they look at this and they say, hey, that top tooth on the left, that looks fine. I don't see anything wrong with it. They don't even bother to look at the one on the second from the left. That's between the teeth. That's no man's land for them. Some of these other teeth, they say, you probably got a cavity or there's some staining in there, but by no means are they aware of what that could potentially be like underlying. And that's not to speak poorly, it's just to say that's just not in their wheelhouse. So this is where we come into play, and we have to be diligent about our diagnosis. Odontogenic infection, same thing. Our medical colleague looks at this, and again, not to talk poorly, but they say, hey, those teeth are white and they're straight and the gums look okay, and he's probably got this awesome mustache, you're good to go. But we look at this and we take a film and we say, no way, right? There's periodontal disease out the wazoo, you're going to lose that tooth for sure. So this is, again, where we come into play. I think the more that we get involved with the management of these patients, hopefully the more our colleagues will become aware of presentations of individuals and still understand the need for dental consultation for these individuals. Restorability is a big one. So, can we restore this tooth? Can I treat this tooth or the tissues involved, and is that feasible for a wide variety of reasons? Can the person afford it? Can they afford not only the initial treatment, but can they afford the treatments that need to follow up, right? You talk about a restoration lasting 7, 8, 9, 10 years on average. Financially, is this person committed to restoring this tooth that often? What's, again, the long-term prognosis? What's the timeline? What is the future restorative dental plan? And then what's the patient's expectations? All of these different things are things that you need to consider relative to the cancer that they're presenting with. Maintenance-wise, can we maintain what we've treated? So it's not just can we treat it, but can we keep it healthy? Again, is that feasible financially? Is that feasible within the patient's time frame? Again, remember, these patients are about to undergo significant surgery, significant treatments with radiation and whatnot. You know, are they going to feel up for driving to come see you for additional treatments, or are they going to say, hey, doc, I feel miserable, I'm staying home, I can't make it today? You have to take a patient's compliance into account. Also, the proximity to dental care. We see a lot of folks that come from St. Louis University, so you know, that can be obviously within the metro area, but also we get some people that are fairly transient where they come from more rural parts of the state up to this area. You know, am I going to recommend a restorative plan for somebody where I'm doing MODs on every tooth? You know, what's their likelihood of maintaining that continual seeking of care? Probably not very high. And the thing that I try to always keep in mind is, are we helping or hurting this person, you know, post-treatment for the sake of aesthetics? And that's something that I try to take seriously. So treatment planning. In terms of the radiation location and dose, we talked about the intensity modulated radiation therapy and the intensity or the image guided radiation therapy, and this is an example of that. What you see on the right here is a person that has roughly a base of skull tumor. When you look at the red section, you see that label as GTV, that's gross tumor volume. And essentially you can read this almost like a topographic map. And so what we see is those more, kind of warmer colors are going to be those higher concentrations of grays that patient is receiving in those areas. So obviously the gross tumor volume is going to be receiving the highest dose, hopefully, of radiation. Like we talked about earlier, we're trying to avoid things like the parotids, right? We're trying to avoid the brainstem. Those are tissues that are very susceptible to radiation. If we can keep from radiating those areas, that's going to be, a huge factor in some of this patient's comfort levels post-surgery. This is a really interesting study that came out in a journal called Oral Surgery, Oral Medicine, Oral Pathology, and Oral Radiology, and it came out about 3 years ago or so. And essentially what they did was they looked at patients that presented with different tumors in different locations of the head and neck area. Base of tongue, tonsils, laryngeal cancers, nasopharyngeal, and hypopharyngeal cancers. And what they did was, these patients, they looked at the amount of radiation that the individual teeth received relative to that person's diagnosis and where the cancer was located at. And the take-home message of this essentially is that posterior teeth are oftentimes going to be more involved. They're going to be receiving a higher dosage of radiation. And that's common because that's where we commonly see these tumors, right? We're seeing oropharyngeal cancers. It makes sense that the posterior teeth are more affected. My big take-home message to you is that you have to be very, very leery of molars, but you have to be very, very leery of particularly mandibular molars. Mandibular molars are the big ones that you have to have a very good understanding about what the prognosis of this tooth is going to be. Can I treat this tooth? Because they are going to be receiving the highest amount of radiation on average for the various tumor locations within the body. Again, prognosis, patient age, and whatnot. Younger patients, we talked about their ability to recover from a surgery as being important. Dentally, you have to flip that around. So from a dental perspective, a younger patient has theoretically going to have to maintain this dentition for a longer period of time versus an older individual. So in that person, you have to say, hey, you've got, hopefully, 40, 50 more years to live with these teeth, an ideal situation. So what can we do to set you up best for the long term? It's very important to keep in mind that the risk of osteoradial necrosis does not go away. It doesn't get better as the person ages. It doesn't time out. There's not a half-life for it or anything. It stays around. It's bad, and it stays there for the duration of the patient's life. So you can't say, well, it's been 30 years, you're probably fine, let's take these teeth out. That's not the way it works. It's still at an area of which it being potentially causing complications with osteoradial necrosis. Patient finances is kind of a tough one to talk about. You know, an ideal situation, everybody gets dental care and they get the best type of dental care that's given to them or that's available to them, but that's not always the reality. And so you have to consider what's this person's ability to not only be preventative, but to be, you know, reactionary, right? If a tooth breaks, can they fix this? And as well as the maintenance of that too. Patient compliance. So this is a big one. A person shows up to our office and, you know, they've got, you know, 2s and 3s on their periodontal probings. You know, do I feel a little bit more comfortable on maintaining teeth in this individual versus extraction than the person that walks in with this big bridge of calculus? Well, for sure, I do. Not to say I don't care, but if this person says, no, I'm going to start flossing, it's going to be good, I'm going to take care of it, I don't believe you necessarily, because history, you know, is going to repeat itself. There was an interesting study that was done that looked at patient compliance with oral hygiene and dental care post-diagnosis of a head and neck cancer. And what they found was that people become more aware, so they are aware of the need for oral hygiene. They're aware of the fact that they should be flossing, and they might step their game up a little bit, but we did not see that in these individuals that are presenting with periodontal disease, that are presenting with cavities, we're not seeing a decline in the presentation of those diseases. In fact, it got worse. So, you know, they might say, no, I'm gonna change, I'm gonna get better and whatnot. You know, we've got studies to suggest that that is not the case. So when I see this, I'm thinking, okay, I don't think that you're going to be able to maintain your teeth like an individual who is presenting in an otherwise, you know, healthy dental fashion. So in terms of the dental factors, your radiographic examination is critical. Reference that panel that we took earlier, right? I think a panel is an important aid as well, and you know that's going to help with detection of some of these cancers potentially. You know, you don't want to go fishing with it per se. I guess what I'm saying is that it's important to get a very thorough, you know, radiographic examination. In my opinion, it's not enough to just take 4 bite wings and a pano. You need to look periapically. You need to rule out periapical pathology in these individuals because you don't want to leave them with the potential asymptomatic but very much, you know, odontogenic infection alive while they're about to start their chemo. They start their chemo, that infection blows up, and now you have to potentially suspend chemotherapy at a very, very critical time in not only that patient's treatment, but this patient's life. So in my opinion, a very thorough radiographic examination is absolutely critical. For periodontal disease, you know, this is going to sound a little bit critical, a little bit harsh, but you know, what we were seeing out of that study that was performed at the hospital in New York was that they were considering extraction on teeth that had pocket depths or attachment loss, that was equal to or above 5 millimeters. So most oftentimes we're saying, hey, we can scale and root plane. Let's see how that responds. Let's see what happens. But what they were doing was a lot more aggressive, but it worked, right? Now you can argue, is that too aggressive? I don't know, but you know, you have to consider that, you know, their presentation at the time of disease diagnosis is not necessarily going to get better as that disease progresses. They're not going to be comfortable. They're not going to want to brush their teeth every day. They're not going to want to floss their teeth every day. Their compliance is more likely than not going to drop. So if you see somebody that has significant pocket depths, if you have furcation involvement, if you had, you know, past history of periodontal disease that you treated, but now they're presenting with it again, you've got mobility, if you've got inflammation, bleeding, purulence, those are all indicators for extraction of teeth. And now this is a very, you know, personal decision, obviously, and these are conversations you have to have, you know, with the patient so that they're understanding. Again, that's a fine line. There's something to say, like we said earlier, for, you know, the patient that can maintain a healthy diet as best as they can. It can eat burgers and eat pizza and those things that they want to eat versus edentulating somebody. And you have to have a very serious conversation with this person about what are your treatment goals? Are you willing to risk some of these complications post-operatively for the maintenance of your teeth? That's something that's very personal between the providing dentist or specialist and that patient. Dental caries, again, you know, if I see that tooth on the left, can I treat that? Yes. If I see that tooth on the second from the left, yes. We start seeing pulpal involvement. If we start seeing, obviously, periapical involvement, you know, once we see caries progress, you know, and it's approximating the pulp, if we're seeing lesions that are contributing to tooth-borne pain, in my opinion, those are all things that are you know, have to have a serious conversation about extraction of this tooth. You know, the last thing that you want, in my opinion, is to try to attempt to salvage a tooth. You do a pulp cap, you know, hey, everything's fine, the tooth is asymptomatic, they start their chemo, they start the radiation, and then bam, you know, that tooth blows up on you. Now what do you do? Now you're kind of stuck between a rock and a hard place. So you have to, you know, consider these different things. You don't want it to develop these odontogenic sources of infection in the midst of these other treatments that are happening. Root canals, again, another interesting to consider. So we all know root canals are on average very, you know, very successful. You know, what this study was recommending, at least out of the hospital in New York, was that, you know, silver points, you know, teeth that have evidence of failing, those are teeth that should be considered for extraction. You know, again, like we said, root canal treatment is generally successful, but we've all been stuck in the trenches trying to take out a tooth that has been root canal treated, and it's breaking down on us, and it leads to a more aggressive, more invasive surgery to try to extract that tooth. Do you want to be doing that, you know, on a patient that has just undergone a lot of radiation therapy? No, you don't want to do that, you know, on a patient that hasn't had that, much less an individual that has had radiation treatment as well. So you need to keep these things in mind. You see a picture like this, and this is, you know, a good debate, right? You see that that first premolar there, and the endo looks pretty good, right? I mean, they got down to the apex, and, you know, it looks like it's got a decent restoration. The margin, questionable. You know, you've got some potential pathology at the apice. Now, is this a patient where maybe this root canal was just done and it's healed and that's some scarring? Is that a new infection that's developing? You know, that's, you know, debatable, and that's where it becomes critical to have these periapical images, to go through the diagnostic steps to confirm or rule out the presence of odontogenic infection on these individuals. Impacted teeth as well. So if teeth are impacted and they're within the field of radiation, those are ones that should be considered for extraction, especially if they're exhibiting any kind of pathology in terms of, you know, operculum, if you're seeing you know, any kind of you know, significant gingivitis surrounding these areas. So I would definitely, you know, take that into consideration as well. That tooth, you know, in this example on this film, you know, we don't expect that tooth to erupt fully. We don't expect that tooth to be cleansable. It already, you know, looks like it's got decay on it, on the occlusal there. You know, why would we leave this in there? You're just subjecting this person to a potential issue, you know, for the management of their disease later on. So medication-wise, there's a couple things that we can do to help aid our patients as they're about to go through these different processes for treatment of the disease. When we talk about radiation exposure and its effects on salivary glands, there's a couple different things to keep in mind. With regards to the dosage that they receive, we do see a decrease in salivary function with a very low level of exposure to radiation. And when you consider that the amount of radiation that's required to treat these diseases is usually in the range of 6,000 to 6,500 centigrades, and we see decreased salivary function with only 1,000 centigrades, it's almost guaranteed that these patients are going to exhibit some type of xerostomia. We want to obviously try to minimize the negative effects of that. We want to take this into consideration. Hey, one of our key allies in the fight against, you know, recurrent decay or primary caries is going to be that salivary buffer, and we know that these patients are going to exhibit a lower ability to produce that. So, you know, are we taking this into consideration when we're deciding our restorative treatment plan? In terms of radiation and saliva, we know that radiation does a couple things to saliva. It's going to decrease the pH. It's going to make it more acidic. It's going to make it more viscous. And when you think about viscosity, you think about difficulty eating, right? Patients will complain, oh, I can't eat the same way. It's not as lubricated. It's tougher to chew and swallow. And what is that going to do? Well, it's going to skew your patient towards a diet that's probably softer, a little bit more carbohydrate laden. Think, you know, your cookies, your breads, things that are a little bit more palatable and easy to, you know, bite than your hard foods that, you know, they can't lubricate their mouth to eat comfortably. It's also going to make your oral environment a little bit more predisposed to opportunistic infections by things like Candida and whatnot. It's going to alter their taste. Again, that's going to skew them towards a diet that's going to be more consistent with, you know, really, really salty things, really, really sweet things. They're going to seek out, you know, sodas, you know, your sugary sweets and whatnot, because they can simply taste those things, and we all enjoy, you know, tasting a good. In terms of radiation in teeth, we also know that radiation does a couple different things to teeth. It's going to reduce the hardness of teeth. It's also going to introduce tensile and shear stresses at the DEJ. And when you look at these teeth histologically that have been irradiated, you see that there's actually this gap formation at the DEJ, and it leads to the enamel delamination on these teeth. So when you look at a patient that has had radiation exposure and they have radiation caries, you classically look at it and see, oh, they've got this cervical decay pattern, the cervical demineralization. It almost looks like your meth mouth in a sense, right? Well, there's rationale behind that, right? Part of it's diet, like we talked about. Part of it is just histologically what's going on with the actual tooth structure itself. And then also when you factor in the idea that the salivary flow is decreased, you're going to develop complications. We're seeing a lot of interesting studies that are coming out now with the effect of radiation on our restorative materials. And so one of the things that I was reading just the other day is we look at composites, for example. Composites are our workhorse. We place them all day. And a bond in a radiated or in a person that has not received radiation is good on the enamel. And then if you've placed that before they've been exposed to the radiation, generally that bond is not seeing a significant drop in its strength. The downside, though, is that we see the potential to bond to radiated teeth, so teeth that have already been radiated. If you then try to bond to that, your bond strength is not going to be as good. So I think that just goes to the argument that you have to be a little bit more proactive. You have to manage disease and the potential for disease before it springs up, because the heavy workforce of armamentarium and composites and whatnot, we know that it's not going to be as effective in its bond strength to the tooth. Now, there's arguments about is that strength, is it clinically relevant? That's still yet to be determined, but the strength is something that you do need to keep in mind when you're deciding your different types of restorative materials to use on these individuals. Pilocarpine is a great drug. I don't know if anybody's prescribed this. It's been around forever. Essentially how it works, it's a parasympathetic nervous system stimulator. So you think parasympathetic nervous system, you're thinking rest and digest. You're thinking salivation and whatnot. So what it's going to do, it's going to stimulate salivation. And it works. We know that it works. It's been around for a while. It doesn't seem to develop a tolerance, which is important because then you can keep giving it to patients and it's not necessarily going to decrease in effectiveness. The downside, though, that people gripe about is that it causes sweating, right? So it stimulates glands, right? And so, you think about salivary glands, good, sweat glands, not so much. So, patients I've encountered that I've worked with that I've prescribed this with say, hey, it's working, but I sweat like a pig. I'm sweating all the time. And so that's not, that's very anecdotal, but, we do know that one of the common side effects is sweating. A different option is a medication called cevimeline or Evozac, and this is the same way. It works in the same way that pilocarpine does. The downside with this medication that is, relative to pilocarpine is sometimes insurance coverage isn't as great. This medication is a little bit more expensive than pilocarpine because pilocarpine's been around for forever. We see that it's a little bit less effective than pilocarpine, but the side effect profile is better, so patients tolerate this more. So if you start them on pilocarpine, they say, hey, doc, I'm sweating too much, take me off. Okay, would you consider trying this? Possibly, because we know that it's not going to work as well, but if they're able to keep using it, that's a great thing. Dental products, obviously, so there's different things that we can do in terms of fluorides and whatnot. So Fluoropal is a great medicament that we can place. This is something that can be placed in a tray that you can fabricate. They can wear it overnight. You can wear it daily. Again, my theory in terms of providing supplemental fluoride to these patients is throw everything at them and say, hey, try this Fluoropal, try this product, and see what sticks, right? Hopefully, a combination, at least one of those things is going to be effective to say, hey, doc, I hate wearing these trays, but, for example, I can brush my teeth with Prevident, and that's, again, hey, that's great. Not as good, in my opinion, but it's better than nothing. We're doing something to fight it. So again, these trays are easy to make. You can just get a blockout resin, just like you would a whitening tray. Plastic, set down, cut it off. I would use the softer trays for this, obviously. Remember, mucositis, you're going to be fighting with stuff like that. The softer trays, really thin material, those are going to work a little bit better. That's going to give it a little reservoir for which that Fluoropal can kind of, interact directly with the tooth right there. MI Paste is another good product, more particularly MI Paste Plus. MI Paste Plus has fluoride in it. MI Paste does not. This works a little bit differently. So this is a topical. It contains what's called Recaldent. These are components of calcium and phosphate that are derived from milk proteins and whatnot. And essentially, these are going to help restore some of those other ingredients that you need for a healthy tooth. So you have the fluoride that can come from the MI Paste Plus, but also you're giving that tooth some of the other ingredients it needs for repair. These also work pretty good for the treatment of white spot lesions. So if you have some of this in your office, that I think Spear came out with a study not too long ago that they showed that it works pretty well for white spot lesion treatment too. So these things can be placed into a tray that you fabricate. They can be placed on a toothbrush and brushed with. People can put it on their finger and put it directly on the teeth. That's another good way of putting it. You can look at this and say, hey, that's a glob of stuff in there. And some patients say, oh, I don't like all that stuff in there. Okay, well, let's try the Fluoropal instead. Let's give you Prevident 5000. Let's give you something. So that's why I like to give them different options, because if they don't like all that goopiness, let's try this as a different means of trying to treat the teeth. Prevident 5000, we all use this stuff. I've had to deal with a couple patients in this aspect. I find it kind of funny where they say, well, it's not working. I said, well, how do you know it's not working? You don't have any cavities. It seems to be working. Well, it doesn't foam up. It doesn't suds up as much. So I've seen people attribute the sudsing of a toothpaste to its effectiveness, which sounds kind of funny, but this will not foam up. It won't suds up quite as much. So, I would coach your patients, say, hey, we're going to give you this medication. It's got more fluoride in it than what you can buy at Dierberg's or Walmart or CVS. And keep in mind, it's not going to foam up. And so it's still working, but it's not going to foam. I sometimes tell folks, if they like their normal stuff, hey, do that in the morning. Use your regular toothpaste in the morning. You get that good sudsy feeling. And then at nighttime, hey, use this stuff. Spit it out. Don't rinse your mouth out. Let it sit on the teeth. Let it stay there overnight. And that's going to get a little bit better penetrance and effectiveness. We can also make radiation guards. So just like you had that suck down tray for the fabrication of a Fluoropal product or a MI Paste product, we can also make radiation guards. And this is the same plasticky material. It's just thicker. So this tray, when you look at right here, it's about 5 to 6 millimeters thicker. So there's different kinds of radiation guards. I'll show you a different style here in a second. But this is a very, very simple type of guard that you can make for a patient that is going to be potentially helpful in reducing the scatter of the radiation they receive. And that scatter is hopefully, or the decrease of that scatter is going to cut down on the mucositis that they might experience. And so when you look at the CT scan, you look at the teeth and you see it's the artifacts that's kind of sunbursting. And what you're seeing is that radiation is hitting those dental restorative materials and it's blasting off into other parts of the mouth. So you got to remember there's a tongue there, there's cheeks there. We don't want that to backscatter into the cheek and potentially leave that person more predisposed for the development of mucositis. The important thing to remember with this is it's not blocking the radiation, right? We don't want to block the radiation, because if you block the radiation, your radiation oncologist is going to say, what the hell, I can't get the radiation to where it needs to go because you've got this dumb tray in there that's blocking everything. All this is meant to do, it's meant to displace. So you're displacing tissue. So you're moving the cheeks away. You're keeping the tongue away. You're pushing tissues out of the way so that scatter effect on the mucosa and the surrounding areas is cut down a little bit. So here's a radiation guard. You can see, the thing that I point out is the drastic change in the vertical dimension right there, right from what their occlusion is. And so when you consider this is why it becomes very, very, very important to have, all of your restorative stuff done as best as you can, especially your significant restorative work that might change the plane of occlusion, change the occlusal relationship between opposing teeth, because you can drastically affect the opening, the interincisal opening, or excuse me, the vertical dimension of these patients. So remember, we talked about this mask. This mask is very form-fitting. So if they go to the radiation oncologist and they get this mask made, and they come back to you and they say, hey, I've got your guards, pop these in. Here's one on the top, one on the bottom. Are they going to fit in that anymore? No, they're not. It's not going to fit. And then they're going to have to throw them away, and you've wasted everybody's time. So again, these are always made before the simulation of the appointment for where the radiation is going to go. So they will wear this the first time they strap this mask on and go for that simulation so that they don't have any significant deviations in the vertical dimension between the two arches, because it won't fit, it won't work. This is another another really a little bit more intricate type of radiation guard. And what you see here is that this is actually displacing the tongue. So we look at it from a couple different views. You have your coronal view. You can see where it's sitting. It's overlapping the teeth. It's displacing the cheek a little bit. But also, more importantly, on the sagittal view right there, you see that little fin. That fin is kind of acrylic. It's sitting underneath the tongue. And what it's doing is it's elevating the tongue. So in this individual right here, they have a floor of mouth, cancer that's down in this location. You can see based on kind of the topography of the dosimetry of the radiation that they're receiving, this is the area they're shooting. But look at the tongue. The tongue is up and out of the way. So if you can displace the tongue, that's going to significantly cut down on the morbidity associated with that patient, and hopefully they're not going to quite experience that same level of mucositis or damage to that tongue, level of discomfort that they might if you had just let the tongue float there and get blasted. I'll be honest, I have not made a lot of these, but a lot of prosthodontists could easily make this for you, especially a prosthodontist that's had additional training in oral and maxillofacial rehabilitation for these cancer patients, and you'll sometimes see those individuals associated with different hospitals and whatnot. So this is a different modality that's an option, but even the other kind is still going to cut down on the potential for mucositis. And what we want to see is we want to reduce things like this, right? So we talked about gold being a bad material. We talked about moving of the tongue. Part of that is obviously the tumor located on that left border of the tongue, but also, if we can displace that tongue and subject it potentially to less of that scatter, if you get the cheek out of the way, subject it to less of that scatter, if we can cut down on that, obviously you're going to improve a patient's comfort level, hopefully significantly. We also want to cut down on this too. So we want to reduce obviously that cervical decay pattern, that cervical demineralization, that really modeled, very tough to restore look. So if we can avoid people going down this pathway by diligent care up front, by sound treatment planning, by being proactive, by prescribing the appropriate modalities, obviously that's a huge effect. And I'll stop with this. I'll leave with this slide. I take this stuff very seriously. I like what I do in this capacity. I think it's important. I think it's also important to put what I do in perspective to the surgeons, the radiation oncologists, the medical oncologists. They're the ones, they're saving lives, right? They're the ones that are saving the life. I'm not saving a person's life. But I do think as dentists, as different specialists, we have the ability to, very much improve a patient's quality of life. And ideally, as we get better at treating these illnesses and diseases and people are living longer, we shift from this idea of just preserving life to preserving and protecting quality of life, which, really means a lot. I think I have a 4-month-old son at home, like I said, and, I know my dad's in the audience, God forbid if that was ever to happen, he'd want to see his kid grow up. He'd want to smile at that grandson. He'd want to, talk with them and share stories. And if we can do that for our patients, that is a tremendously life-altering service that we can provide these individuals. So I told you I'd get a photo. So this is Joshua. He's 4 months old. I think he's super cute. I'm biased. But I really appreciate you all listening to me. And I open it up for questions. Thank you. I'll be honest, I don't know the answer to that. I would say that there's probably more contraindications to the expedited versions of ortho when you're doing like elective, periodontal procedures to expedite the movement of it. I don't know what studies exist on that, probably more so because the age range that you're talking about is just not as going to be commonly seeking orthodontic care. I'm sorry, I can't answer that honestly. But I would say, in general, in my opinion, less is more. The less you can get involved with, significant dental care, the better. What's up? You.
Question. So when it comes to if you were to edentulate a patient, okay, what would be the best prosthetic? As in, so there's a debate: should you do implants and have a implant retained or implant supported denture or a denture? And so in your experience, you know, anything in regards to what would be the best, prosthesis for them?
Yeah, so traditionally with the patients that we treat, it's more removable appliances without the support of implants. Implants are a possibility in patients that have received head and neck radiation. There's lots of studies about that. Now, I think sometimes the tougher thing is finding surgeons that are willing to put implants into a radiated bone, but there are studies that suggest that they can survive in an irradiated bone environment. I would say things that are minimizing mucosal trauma are always going to be better than things that don't. If you can get a prosthesis that is elevated off of the mucosa, off of the supporting tissues, that's going to be better. If you can't do that, if you have to have a tissue-borne appliance, then in that case you have to be diligent about paying attention to path of draw, if they're going to have significant denture sore spots, the ability for that patient to come back in and get those sore spots adjusted. You have to be really, really staying on top of that. And traditionally what we've been doing is letting people heal, about 4, 5, 6 months or so post-surgery, post-radiation, letting the tissues calm down, and then looking into making a denture. So I think pre-prosthetically going into that kind of stuff, a little bit more diligent, not only with the dentulating people, but dentulating people with an intent to pre-prosthetically create an environment which I can put a denture in place that's going to be feasible, versus saying, okay, we'll take the teeth out, we'll see how the bone heals, and then we might go back in and do some adjustment, do some alveoplasty and whatnot. I think that's an important thing to keep in mind too. So I think, answer your question, implants work. Do people want to put implants in? Not so much. There's interesting stuff coming out about the use of actually bisphosphonates to supplement the healing of the implant then after the implant's gone in on a patient that has been irradiated. There's medications that we can prescribe patients that will hopefully help with the bony healing. I didn't talk about it in the lecture here, but there's essentially medications in the form of vitamin E is a big one, and then also a medication called pentoxifylline, which I know we've talked about, but basically it works by kind of making the blood cells a little bit more adaptable and slippery, more or less, so that you can get perfusion of blood, ability to heal to some of these areas that have otherwise been compromised by, the fibrosis scarring of the vasculature secondary to radiation. So,
As a follow-up to that, in the post-Gulf War era, with a lot of new biotechnology stuff, we've been seeing patients using some additive medicaments. I didn't see any of that for mucosal healing in post-radiation therapy patients, or wound sort of management.
okay.
And some of these new materials are really interesting. They're kind of new on the market. I don't know if you have seen any come out of the blue.
I have not. Do you have an example or two?
I don't offhand. I know that there's a bunch of, they're using new sort of somal tissues, right, where they're very soothing. And there's a couple of companies that are pretty good. But I'm seeing you use, that's why I was curious. I don't know names offhand, but there's a bunch of them on the market right now.
Yeah, no, I have to look into that. I guess another medicament we didn't talk about would be, your magic mouth rinses are obviously great, your viscous lidocaines and whatnot. Some people, they don't want to get it compounded. It's expensive to get it compounded. I've even recommended, it sounds funny, but just taking Maalox or taking Pepto-Bismol and putting it in your mouth and just kind of swish it around, spit it out. It gets kind of that coating that has a good effect too. There's some medications that people are given for, GI ulcers, like sucralfate, I think, if I'm pronouncing that right. I always have trouble pronouncing that, but it's a medication that coats ulcerations and whatnot. It's sometimes included in those different compounds. And so these are things that are not, stimulating necessarily reparative like what you're talking about, but it's definitely a medication that you can use to help with comfort levels for patients.
You're going to make the patient eventually before surgery or radiation anyway. If you put the implants in anticipation of putting a denture over it later, do they integrate or does the radiation keep them from integrating?
I can't quote you studies on that. I think that's still kind of up in the air. I hope that I think the tough thing to study about that is, okay, you have to have a patient that's willing to do it, and you have to have a good rationale. We don't really have that great rationale all the time yet. It's still kind of iffy. I think there's a lot to say for, again, the hygiene compliance part of it too. Are they going to be able to maintain, that immaculate oral hygiene while they're going through these phases with the radiation chemo where they're not going to be comfortable in order to do so? I can't answer that honestly. I need to look more into that for sure. And I think overall as a field, we need to do probably better with that too.
Is there a test for the risk of osteoradionecrosis pre-extraction surgery?
Is there a test like a blood test or?
Biopsy or something like that, or just to see if there's blood present in the brain?
I would say not that I'm aware of. They're doing some. And I've read this. This is a little bit off topic, I guess, but with endodontic stuff, they're looking more into Doppler and things that can assess true pulpal vitality, where you can see if there's perfusion into a tooth, where that tooth we can assume it's vital because it has good blood perfusion to it. I'm assuming you could expand something like that into the alveolus. And I know you use it for if you did an anastomization to a facial artery or whatnot. You're checking to see if you've got perfusion of that blood supply into the connected vessel that you attached. There might be means to do that to say, okay, you have a sufficient level of vascular flow. There's different studies that can look at imaging studies, that can identify vasculature and show levels of perfusion based off of just the inundation of the vessels in the area. So there might be ways in which you can look at those different images. You could combine some of these more novel techniques to do it. To answer your question specifically, not that I'm aware of at this time, but I could see that potentially developing.
I have another question too. Is it the standard of care for us to discuss the HPV vaccine for our patients now?
This is strictly my opinion. Hopefully they're getting it very, very early on from a pediatrician, right? Hopefully it's something that they're getting, before they even are at that age point where in which you might have that conversation with them. I think it's within your scope. I think it's within your scope to do it. Now, I think, it's still a little bit taboo, and I think you have to take into consideration the age range that you're discussing with. So, are you going to bring this up with a patient that's 45 because, yes, they qualify for it? Sure, you can. Is it going to be super effective for you to recommend that to them? Probably not, because the statistics say that they've been exposed to it already. Now, is it different to have that conversation with the mother of a 9-year-old? Sure, for sure. I think it's within your scope to say, hey, I'm sure the pediatrician's telling you about these different vaccinations, and this is what we're seeing from a dental perspective and from an oral health perspective. And if there's a vaccine, effectively, what you're saying is there's a vaccine that we have that can prevent cancer. Do you want that vaccine? I think that's fair to suggest within your scope.
Does the HPV lay dormant in your body like the shingles virus?
I don't know the answer to that. I'm sorry. It's in your body. It's in there. You've had a immunological response to it. You've had antibodies that have been developed to it. Now, to get specific about the definition of dormancy and where it is at in the body, I don't know the answer to that. But your body definitely reacts to it and knows that you've been exposed to it.
And then one more, does the pilocarpine work for patients that have a side effect from other medications where they have decreased saliva?
I've tried it. To me, it's a very much like, let's throw this at you and let's see if it works.
So you had success with it?
Yeah, I've had success with it. Now, you have to be a little bit careful with patients that have significant cardiac morbidities, just because you're stimulating the nervous system in a sense. So if they've already had cardiac complications, you don't necessarily want to slow them down even more potentially. So you have to be leery of that. There's also some complications with people that have had various eye issues with I want to say glaucomas and whatnot. So you have to be aware of eye conditions and then cardiac conditions specifically for the prescription of these medications. Again, it doesn't. What I tell patients, when you use this medication, the idea is I'm going to give this to you ahead of time, and hopefully it's going to ramp up your salivary production, and then you're going to get blasted with radiation. It's going to drop it down, and hopefully it's going to drop it down to a level in which you were more or less at before you went down this road. What it's not going to do is it's not going to repair the salivary gland. So the salivary gland is damaged. It's not going to make that gland get better. It might make the cells that are producing saliva within the gland a little bit more effective, but it's not going to treat it and make that condition go away.
Is there any artificial saliva that patients like on the market?
I don't think so. I mean,
One that's worked best for you?
I mean, I with Biotene, for Biotene's the classic one. I think people find it kind of like oily and they don't like it. It sounds silly. I'll tell people, hey, use it before you eat. And the idea is you've kind of lubricated your mouth beforehand, and then you eat, and then hopefully you've tolerated the idea of eating and chewing a little bit better. There's kinds where it's a spray. Oasis is one brand you'll see. Biotene Spry is another one.
The Sadly melts, I've had patients like those.
Yeah, yeah,
And then green tea,
yeah. I mean,
just green tea.
yeah. I mean, the thing with the xylitol, you have to take a ton of xylitol for it to get that effect. That's what's kind of like hidden out there is xylitol fixes. No, you have to take a ton of xylitol. But yeah, I mean, I think candies are good when they're sugar-free. And that's something, especially, like sugar-free lemon drops or something like that. Something that's kind of acidic in that nature that's going to naturally stimulate your salivary, functions, but, not do so in the presence of sugar and whatnot.
My experience at the VA with pilocarpine, doesn't work for me.
Yeah.
But in 26 years there, most of my patients that were head and neck, by the time they got to us, they had already had everything, and they were as dry as the tabletop.
Right.
We give them Salogen,
Yeah.
and they can take it up to 6 times a day and have no increase. And even the ones that say, I got a little bit of increase, and a little bit is better than being as dry as this. But their cardiologist would take them off of it because they didn't like the
Yeah.
increase in that. And because we were in the VA, the physician won, and, they couldn't take it anymore.
Yeah.
But it got to the point that these people have had so much change of their life that to keep giving them more medications, they want to be done with stuff.
Right.
So they want to go back to the way things were beforehand, when they took almost nothing. So here's the thing that's limited in success, just like the Biotene, the Oasis, they'll try it, but if it doesn't give tremendous increase and relief and it's permanent, they just quit buying it.
Yeah.
And they quit using it. So
Yeah.
the Salogen, a lot of sweating, a lot of increase in blood pressure, and cardiologists were not happy with that.
Right.
Patients didn't get enough success with it to say, I don't care what my cardiologist says.
Yeah, no, I agree with what you're saying. And I would be hopeful with our improved radiation modalities and whatnot that as we get better at
Right.
targeting specifically.
The way they were doing radiation
Right.
25 years ago, 30 years ago,
Right.
is all different. So with the targeting, the parotid may not be as effective as much as submandibular, may not be as effective as
Right.
much, and they may have much greater salivary flow post radiation. They may also have less ostomia, they may have less cervical decay.
Yep.
So-
Yeah.
And as far as implants, the big problem with the implants is what they're going through is so costly for you to say, well, if we can put 2 or 4 implants in and the cost of the implant surgery and all that, they're so overwhelmed by everything, they're not sitting around with another $20,000 to be thinking about, I want to add this to the situation. If you put them in the anterior mandible between the canines, you can put anything in there anytime and get 92-95% success rate. The longer you wait to load the implants, if you can wait out to a year, it's better. The VA and the government put out a paper on edentulosum and radiation about 3 years ago, 2.5 years ago, and their recommendation to all the VA medical centers was not to make dentures until a year after surgery and radiation to give the most amount of bone and soft tissue healing.
Yeah.
So, I mean, people are gonna make them much faster than
Right.
that, but the government had actually gone to saying, this is what the protocol is, so we longer you wait, give the surgical healing better. If you got implants in there, the longer you wait before you load them, better off.
Yeah, my hope with talking about implants would be hopefully that we get to a point where you don't even need to involve a bone graft at that point where, you know, those plates that you saw, those are custom milled. I can't imagine the piece interface is obviously in different companies, but who's to say you can't have a plating that also incorporates an implant body into it, and then you take the idea of a bone, you know, an implant interface off the table, and then you have, you know, a crown that can go into a plating that has an implant body essentially into it. If that makes sense. I think that'd be really neat. I don't know if we're there yet, but a lot of those surgeries now, they're designed three-dimensionally on a computer. And so it used to be you go in there and size this plate and cut it down and do all this stuff. I mean, they can be made prefabricated before you even walk into the surgery, and it just clunks right into place. So if we can get to that point, I think that'd be pretty amazing.
And then they're also doing tibia grafts.
Yeah.
Implants, put them in beforehand, letting osteo integrate into the bone
Yeah.
for 4 months before they harvest the bone
Yeah.
and put it into the jaw. And, there's
It's cool stuff.
a lot of weird dreams that are
Yeah.
coming true.
Yeah. 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 Cool. Yeah. Well, thank you, everybody. Appreciate it.
I knew when you walked in with the tie that would be in for a treat. Okay, thank you so much. Have a great night.